Go.
Thank you, Sakiti. It's an extreme, I don't know, like how to put it in words. It's a great honor to have Dr. Kamini Rao ma'am joining us for our meeting of assisted reproductive specialist in Trichy, Tamil Nadu, Trichy, Thanjavur and Tiruvarur of Tamil Nadu. Thank you so much, ma'am, for joining. We would like to welcome you to the program. The other speaker is Dr. Pandian. Sir will be joining from US, where is gone now, and both of you have taken such great pains to give us inputs on the topics where you are kings and queens, and we are honored, and it will be of great help to every junior who is joining, so that we get to know the basics from you, and then probably it will help them to go forward. And I would like to welcome all the delegates who have joined, and thank you so much for taking out your precious time to join with us to listen to these stalwarts talk to us. And I would like to, I don't think Madam needs any introduction in any part of the world, but it's my honor to introduce Dr. Kamini Rao. She is the founder chairperson of the Medline Academics, which is an e-learning portal. Her present affiliations are she's a chairperson of the National Registry of ART Clinics and Banks in India. He's the editor-in-chief of the International Journal of Infertility and Fetal Medicine. He's a member of the National Advisory Committee for drafting of guidelines on ART. And her major achievements, she's been awarded the Padma Shri in 2014 in recognition of the distinguished service in the field of reproductive medicine. She's got an honorary fellowship of the International Academy of Human Reproduction based on contributions to the science of human reproduction and on recognized international prominence in May 2021. She's got a Lifetime Achievement Award from ISAR and FOXY. She's been the chairperson of the drafting committee for the ART bill. She's got the honorary doctorate for Doctorate of Science at the 54th Annual Convocation of Bangalore University. She's been honored with the Vidya Vibhushan Award in 2021 by the Indian College of Obstetricians and Gynecologists. She's been awarded the Outstanding Women Obstetrician and Gynecologist Award by the International Federation of Obstetrics and Gynecology, FIGO. She's got the Distinguished NB Teacher Award by Association of National Board Accredited Institutions. She's published several books, and of note is it's a book which we follow as a Bible. She's the author of the Infertility Manual for the 4th edition, and she's also edited the Principles and Practice of Assisted Reproductive Technology. It's my honor to invite Dr. Kamini Rao to give a talk on the evaluation of female infertility.
So, thank you very much, chairpersons, and of course, having Jam there, sitting and smiling there gives me so much of satisfaction, and I look forward to meeting all of you again and again. I start my talk very soon now. Okay, and let's go ahead. It's a very simple topic, but nevertheless very important. And I hope that I will be able to talk to all the youngsters there. And this is very important because this is going to be the basic thing as far as the ART guideline is concerned.
Madam, you're muted, madam. Sakiti, you have to unmute, madam, please. She has to be made a host. Madam, you're unmuted now. Yes, yes.
Okay. Can you hear me now?
We can hear you, madam, but your slides are not there. They have gone.
The slides have gone?
They're not seen.
What happened?
Now?
Now?
No, ma'am.
No, madam, we cannot see. I'll just download because I got it from Ms. Das, your slides. I'll just download it.
No, I'll do that myself here, no? 1 minute. Okay. We'll just get it for you. This
1 minute. Yes, ma'am, it was visible. Yeah.
It's seen?
Yes, ma'am.
Okay.
Ma'am, please make it full screen, ma'am. Yeah.
Yes. Is it seen now?
Yes, ma'am. Perfect, ma'am. Thank you.
Uh, okay, then. Fine. So a little bit of distraction keeps the mind a little bit more awake. It's always said, and I hope that's right. Okay. So it's always also said that when we look at infertility, what constitutes infertility? And we need to make sure that we will look at infertility as a failure to conceive for at least a year of unprotected intercourse. So the conception in the first month is about trying. When you try in the first month itself is only about 30%. So it's not like you see in all the Hindi movies, first act, and then you say that the woman comes back and she says, yeah, I'm pregnant. So it doesn't work that way. But the chance then falls steadily to about 5% at the end of first year. So when you understand the terminologies, okay, primary infertility, of course, when the woman has never been pregnant. Secondary, when she has been pregnant, but where there has been a viable pregnancy followed by an inability to conceive. When you talk about fecundability, probability of achieving a pregnancy with a single menstrual cycle. But when you say fecundity, it's the probability of achieving a live birth within a single menstrual cycle. So, when do you actually evaluate the woman? In the absence of any exigent history or physical findings, evaluation and treatment may be initiated at about 12 months in a woman who's less than 35 years of age, and at least 6 months in a woman who's more than 35 years of age. So, in women who are about 40 years of age or more, I think when she comes to your clinic, I think immediate evaluation is required and treatment may be warranted, particularly because the ovarian reserve would be going down. When should we evaluate earlier? Suppose this woman comes with irregular menstrual cycles or cycle length which is less than 25 days or more than 35 days. Or has there been any intermenstrual bleeding, oligomenorrhea or amenorrhea, known or any suspected uterine or tubal peritoneal disease, stage 3 or 4 endometriosis, suspected male subfertility, sexual dysfunction, or any kind of genetic or acquired conditions that can predispose to diminished ovarian reserve or chemotherapy, radiation, or exposure, and the fMRI premutation. Now let's look that prevalence of infertility, according to the WHO, all over the world, it is roughly around 15%. But in India, it is very varied. That means it can be as less as 4% to even as high as 16%. The prevalence is varied from state to state. And even in the same region, it varies according to the caste and the tribes. If you look at the south, it can be even as high as 30%. But if you were to see an Indian average, it would come to anywhere between about 15%. But if you look at central India, you will see that it can come to 10%. So if you look at the overall percentage, we would look at somewhere around 10 to 12%. But do racial and ethnic factors impact the reserve in the ovary? Now, ovarian reserve is the number of follicles that are present in the ovary which allow the woman to be fertile for a longer time. So, the Indian women had an earlier onset of decline in the antral follicle count and nearly 6.3 years earlier than the Western cohort. Now, why is it so? AFC, that is antral follicle count, in an Indian woman was lower by a factor of 2.3 times compared to the Western cohort, because Indian women tend to have their menarche much earlier. They tend to start their menses around the age of 11, 12, whereas our Western cohorts would start somewhere around 13 or 14. Also, they reach menopause in the Western Caucasian population around 50-55, whereas we tend to reach menopause around 48 to 52. So there is a faster decline. It either could be because earlier menarche, earlier menopause, or the rate of decline per menstrual cycle also is much more in the Indian population. So if we looked at the general principles, both partners to be evaluated simultaneously. And when we look at the causes of infertility, the male factor will approximately be about 40%. Female factor will approximately be the same. Then you have both factors combined as a 10% and unexplained as 10%. Though, of course, in the present scenario, it has dropped to almost 2 to 3% because of expert diagnosis and because of technology. When you look at the medical and surgical history, any kind of surgeries, hospitalization, details of medical disorders, any medications and allergies must be taken down in great detail. Any endocrine disorders, hirsutism, galactoria, and dyspareunia, lower abdominal pain, and pap smears must be taken. Now, looking at the social history, where we give scant respect to is the occupation, the use of steroids, tobacco, alcohol, and of course, drug abuse. Environmental exposure to gonadotoxins, etc., are another thing that must be kept in mind. Sexual history is something that all of us keep, shying away. Should not. We should be very open. Talk to them, because if you don't ask, they will not tell you. So frequency and timing of intercourse is important. Any dysfunction, previous contraception, what was the duration of infertility? Because they could have been married for 10 years, but the husband would be living somewhere else, wife somewhere else. Secondly, there could have been a problem where there could be some kind of marital disharmony, and therefore they would not have had any sexual relation for about, say, half the period. And another thing, it could be a second marriage, with the first marriage for the woman having ended in a divorce, and the same for the husband. So cause of the divorce also should be checked, and previous fertility with the previous marriage. Evaluation and treatment also should be noted. The menstrual history and age of menarche, the cycle, dysmenorrhea, flow, etc., etc. The more detailed your history is, the more closer you are to your diagnosis. And details of the previous pregnancy must be taken in great detail. The family history of birth defects, mental retardation, early menopause, all that is important. Now, this obstetric history, I'm sure all of you are very, very good at, is biochemical pregnancies, clinical pregnancies, as well as ectopics, live birth. And of course, when you've had your second partner, have you conceived with your first partner, assisted conceptions, complications in your obstetric career, and congenital abnormalities. The examination is a second step, which is very important. Thorough physical examination, which includes all this: weight, BMI, blood pressure, thyroid, breast examination, features of androgen excess, acne, hirsutism, balding, important. We tend to forget in infertility to do a pelvic examination, because we think that we can only do a transvaginal scan and everything is available. My dear friends, do not forget to do a speculum examination, discharge, and also looking at the cervix and a pap smear, very important. Pelvic and abdominal tenderness also can be elicited. Mass or organomegaly should be noted. Uterine size and shape and tenderness and mobility all are to be recorded. Now, when you look at investigations, this is very important. How much should you investigate and how little should you do it? A systematic, expeditious, and cost-effective manner is what I would suggest all of you to do, and to identify the relevant factors. The initial emphasis is on non or least invasive methods and focus on the detection of the most common causes of infertility. The pace and extent of evaluation should take into account what the couple want, the age of the patient, the duration of infertility, and relevant features of history and physical examination will then decide what kind of investigations you should do. So basically, a few factors have to be taken into consideration. One is the ovulatory function, the reserve in the ovary, and whether ovulation is occurring. The second will be the tubal factors. Third is the uterus. And fourth is the systemic factors like the endocrine and other factors. So when you look at the evaluation of ovarian factors, anywhere between 15 to 45% of cases of female infertility are due to ovulatory dysfunction. Though oligo or amenorrhea may be present, yet in some cases, there still will be subtle abnormalities with normal menstruation, and in cases of ovulatory dysfunction, including PCOS, there could be obesity, perimenopause, weight gain or loss, strenuous or excessive exercise, thyroid dysfunction, and hyperprolactinemia. Here you will see in this particular picture a bit of endometriosis is detached into the ovary. So how do you approach the ovulatory function? In most women whose cycles are regular and predictable, generally 21 to 35 days, oligomenorrhea, amenorrhea signifies an ovulation and warrants further investigation. 2. If luteal progesterone, that is reliable and objective measure of ovulation, if obtained at the appropriate time in the cycle, then approximately 1 week before the expected onset of the next menses, rather than any one specific cycle of day. So if you had a cycle which is about 28 days, then perhaps day 21 would be the right time to see the progesterone value. So if the progesterone value done on day 21 of the cycle shows you a value of over 3 nanograms per ml, then it is a presumptive diagnosis and sufficient evidence of recent ovulation. So there are so many ovulation predictor kits that are commercially available. And of course, urinary LH kits are also there to provide indirect evidence of ovulation. Then we have the transvaginal ultrasound, which is almost like the third eye of the Shiva for the gynecologist, where they can see a day 2 or day 3 antral follicle count. And you can identify ovulation when you monitor the cycles. The basal body temperature was an old method to see serial daily testing. And if there is a biphasic approach, a dip just before ovulation and a rise following it, it shows that ovulation has occurred. So, and ovulatory cycles will have a very monophasic temperature pattern. So let us look now and understand why are we worried about the ovulation induction. It's only because let us know how much of ovarian reserve does this lady have. The reserve testing aims to assess the reproductive potential as a function of the number of oocytes that are present in the ovary. So if we know that the ovarian reserve is good, this of course will depend upon the age of the woman, the antral follicle count, the AMH hormone, the FSH, and the inhibin. For us now, the goal of ovarian reserve testing is to identify women who may be poor responders to ovulation stimulation and hence tailor make the protocol to suit them. So all ovarian reserve tests should be interpreted in the context of the entire clinical picture and consider the risk factors and prior treatment and response of the patient. So let us now see which are the tests assessing ovarian reserve. So say, for example, you want to do the AMH. That can be done any time of the cycle, and the abnormal value will be when it is less than 0.8 to 1.1 nanograms per ml. When you look at the antral follicle count, ideally done between day 2 to day 4 of the cycle, and if it's less than 6 to 10, then again it shows a poor response. What about estradiol? Cycle days day 2 to day 4 with a test of FSH as well. Then, if the estradiol levels are more than 80 picograms per ml, then also it's an abnormal response. What about FSH? Now, cycle days of basal values of days 2 to 4 with the test of estradiol, and if the value of FSH is more than 10, it also shows a diminishing reserve in the ovary. Now, look at the antral follicle count, that is the AFC, in the ovary on this scan over here, the right ovary and the left ovary. If the antral follicle count is less than 4, the interpretation is very low and expected response to FSH will be also very poor. But suppose it's between 4 to 6, it's low and the response will be poor. If it is 7 to 10, it will be reduced and expected response to FSH again reduced. But if it is between 11 and 30, it's normal and the response is good. But if it is over 30, it is like a above normal and a PCOS, and there's a chance of hyperstimulation. The pelvic assessment must be looked next, and that is for discharge, any cervicitis and polyps. The cervical smear may be done at the same time so that you don't miss the chance of diagnosing early cervical cancer or cancer in situ. And the next is, of course, history. Previous cervical surgical procedures or abnormal discharge should be addressed and treated completely. The uterus abnormalities occur in roughly about 1/5 of women presenting for infertility evaluation, like polyps and submucous fibroids and adhesions. And ultrasound is a good imaging modality to assess the uterine myometrium, endometrial cavity, and the surrounding adnexa simultaneously. Uterine pathologies such as leiomyomas, endometrial polyps, and adenomyosis can be identified. How do you actually test the tubal factors? This is an age-old technique, I'm sure, in most of the tier 2 and 3 cities. Also, the good old HSG is available, and this is done in the X-ray department, and therefore the HSG is still one of the gold standards that has been used. This can actually reveal the architecture of the tube and also suggest fimbrial phimosis or peritubal adhesions. The tubal patency ascertained by the appearance of fluid in the cul-de-sac with saline infusion, and it does not differentiate between unilateral or bilateral patency. Can, however, delineate the uterine cavity and its pathology well. And that's how sonohystrography can give us real-time images. Now let's look at the peritoneal factors. All right. So if we were to look at the tubal factors, you've seen this through the X-ray. Now looking at it through the laparoscope, the peritoneal factors such as endometriosis and pelvic or adnexal adhesions may cause or contribute to infertility. Peritoneal factors also be considered in women with unexplained infertility. History and physical examination findings may raise suspicion but are rarely sufficient to make best identified with a laparoscope. So, a summary of the evaluation will tell you that ovulation can be looked at even with a menstrual history and the luteal progesterone and the ovulation predictor kits. A test not routinely recommended is the basal body temperature. So, the endometrial biopsy also is not a routine method of assessing ovulation. The transvaginal ultrasound is now the most preferred route to be able to monitor for ovulation. The ovarian reserve can be measured with the AMH, the antral follicle count, the basal follicle stimulating hormone, and estradiol. Test not routinely recommended is the inhibin B. Other endocrine systems are the thyroid stimulating hormone, the prolactin, and androgen measures are not routinely recommended. So, if you looked at the uterus, then evaluation is by the transvaginal sonography or the saline infusion ultrasonography. Test not routinely recommended is the MRI. The hysteroscopy and the hysterosalpingography is also recommended for the uterus. Now, fallopian tube patency is again with the hysterosalpingo contrast sonography. And of course, another thing that one will have to do is a chlamydia antibody test. The laparoscopy with chromoperturbation is recommended only if the hysterosalpingo contrast sonography has not been conclusive or needs further evaluation or needs to be corrected, then laparoscopy becomes an operative laparoscopy, and therefore the tubes can also be cleared, and therefore laparoscopy becomes an operative laparoscopy. So, my dear friends, initiating infertility evaluation depends on duration of infertility, age of the woman, associated suspected pathologies. So, I would suggest strongly that the couple should be seen and counseled together. The evaluation includes assessing ovulatory status, the structure and patency of the female reproductive tract, and semen evaluation of the male partner. Couples with known genetic carrier status or the need for pre-implantation genetic testing may warrant a fertility evaluation before treatment. Advanced sperm function testing, postcoital testing, thrombophilia testing, immunologic testing, karyotype, endometrial biopsy, and serum prolactin are not recommended as part of the routine infertility evaluation without other clinical indications. So, I would say that with basic investigations like this, I'm sure all of you understand that just doing a clinical history and examination quickly may not be as simple as you think, because more detailed your history is and your clinical examination is, the less you need to investigate and the less cost to your patient. And I will conclude this by saying that with Medline academics that we have, we run a lot of courses, all basic and advanced courses. So therefore, any of you wanting to come in for any of your courses, I think you have the website here. Please do come in and have a look at the website. Thank you all very much. Thank you.
Thank you so much, ma'am. All of us have learned our basics from you, actually. So it was a recap of what we have learned from you, and you made it so precise that people can understand every point which you have put across. There are some questions in the chat box. Can I ask you, ma'am?
Please, go ahead.
The first question is by Dr. Shanti, and she's asking early evaluation in stage 1 and stage 2 endometriosis.
Early evaluation A is symptoms of the patient in terms of her menstruation, dysmenorrhea, congestive dysmenorrhea is one. Second thing is pelvic ultrasound, 2. And the third thing is if this is diagnosed with the pelvic ultrasound, one will then have to look at how big is that the chocolate cyst, or does the chocolate cyst need to be taken out? And it also depends on whether infertility needs to be treated, or infertility, that is, does she need a child, or is it only the dysmenorrhea that needs to be treated? It has to be decided. So if it is stage 1 and 2, I think medical management should suffice. But in young patients, you'll find that it can progress to stage 2 and 3 and 4, because it is very much estrogen dependent. So if I find that people are young and they are in stage 1 and 2, I'll still prefer a medical treatment. And if they are interested and they are married and they are still wanting to have a baby, I will encourage them to have the children faster for 2 reasons. One, that it could be an end to endometriosis as well. And the second one is, why wait when you're already decided to have a baby? The second thing is that if they're not willing to have a baby, I would even suggest to them that at least freeze your embryos, so that we don't have a problem later on. And then you can go ahead and do a medical treatment for them and wait and watch. But I wouldn't go straight away and start doing any surgical treatment if you can avoid it.
Suppose she is stage 1, stage 2, and we have got a suspicion of that, and she doesn't want a baby now, can you put her on Dynegis until the time she wants to conceive?
Yeah, you can. That's why I said medical treatment would be in this regard. One is Dynogest, the 2 milligram Dynogest. And also there have been times when you can give Dynogest for 3 months, but also if you give letrozole of 2.5 milligrams along with Dynogest 2 milligrams, you'll find that those women who have adenomyosis and who have endometriosis, the letrozole, because it's an aromatase inhibitor, it tends to take the pain away. So this aromatase inhibitor letrozole is not given for 5 days. It is given continuously, and it can be given continuously for 3 months.
The hypoestrogenic effect of letrozole will be troublesome for some patients, madam.
No, there is no hypoestrogenic effect of letrozole, because here it's not it's an aromatase inhibitor. That's all. So it's unlike clomiphene citrate. It does not actually cause that hypoestrogenic effect. But what is important is it takes the pain away.
Okay.
Very important.
For an adolescent who was diagnosed with endometriosis, can we give that combination if she's having pain?
You can give Dynogest and you can give letrozole. Yes.
Okay. Thank you so much, ma'am.
But some people prefer to give them oral contraceptive pills and continue. And this oral contraceptive pills, of course, make sure that the liver function test is fine. They're not obese. Make sure that their clotting factors are fine, because these are some things that you will be very, very caught unawares of cerebrovascular thrombosis, because you will have to have a clear checkup with the hematologist in these cases. So for medical legal reasons also, please make sure DVT and all these things are supposed to be cleared before you put them on the oral contraceptive pill.
There's another question, ma'am. If there's an AMH value which is of higher level in that patient, but she's got a poor response. AMH is very high.
If AMH is very high and there is a poor response, it's only because you have not stimulated the patient right. Because when you have a very high AMH, it'll be more the PCOS condition. So if this AMH is in the range of 10 or 12, what I would suggest is put them on OCPs for a couple of months. Look at your FSH and LH. Make sure that you get that tonic LH down.
Yes.
It's not a clonic LH, it's a tonic LH. After that, you use ovulogens, that is letrozole, and then you stimulate with pure FSH. But also do an stimulation with maybe 150, depends upon the woman's age, and also counsel her that she may actually throw up like popcorn at some stage, and make sure that she may have to go in for egg pickup if she throws up quite a lot of follicles, so that she is not taken unawares, because once they get stimulated and the FSH receptors on the follicles get stimulated, then you cannot do anything about it. Even if you stop the medication, they'll still grow. So that will be the only thing that you need to be careful about. And if you have your own setup where you can do the egg pickup, then you pick up the eggs and then you store the eggs, and just make sure that you bung down that cycle. Don't allow her to get pregnant. Then you use another cycle, wait for some time. She may not want to use those eggs because she's not going in for an IVF. So next cycle, even with just letrozole, that is, leave that ovary to come back to normal. It may come back to normal in one cycle or two cycles. After that, you stimulate with just letrozole and she'll come out with a monofollicular response.
Thank you, ma'am. And Dr. Jayamkaran has asked, like, place of laparoscopy in high AMH.
Place of laparoscopy today is really redundant at the moment, because most of the people, when they actually use the laparoscope, the question of the rule of four, four areas putting it in and 4 millimeters deep and all those things. But people don't realize that the current can also cause a lot of damage to the cortex, and you can find that adhesions also occur, and people prefer, medical treatment for these people. And when you are actually treating them medically and you're able to sort of get the kind of stimulation with all the kind of modern medicines that we have, with particularly recombinant, I think going in for ovarian drilling really is not required.
Thank you, ma'am. And antibiotic.
People used to resort to ovarian drilling at the drop of a hat. Pardon?
Yes, ma'am. Yes, ma'am.
But I would say that it's a last resort. Pardon?
Yes, ma'am.
Antibiotic of choice when
Chlamydia
and
yes.
Well, I think with chlamydia, you know fully well, no? What do you all give? You tell me.
Doxycycline works better.
Doxycycline, tetracycline, doxycycline. That is the thing that will work. So the same doxycycline you give 100 milligrams.
How many days, madam?
Some people say 5 days. Some people say 10 days. So doxycycline, yes, you need to give. That no doubt. Sometimes even without even testing, the testing itself costs a lot of money. Just giving them a full course of doxycycline is cheaper.
Yes.
Then going and testing it and then getting your results, because it's much cheaper in most places. And by the time in all these tier 2 cities, by the time you get that back also, that is another waste of time. And if the results are not conclusive, again, you'll give them doxycycline. So better just give doxycycline.
Okay. And Dr. Yukti Bharadwaj said she wants webinars with you every month.
Who?
Dr. Yukti Bharadwaj, she has mentioned that she wants webinars with you every month.
Yes, good. I'm very happy. Our Medline is actually doing these kind of programs, basic fertility, all the infertility, plus for medical legal. So I think
Yukti, you can join that.
Pardon?
Madam, I've asked
There's one.
Yukti to join that program.
Yeah, definitely.
Yes.
And when a patient needs to be referred to art center by a gynec, what do you need to mean? What is that?
When do you refer
Jam?
when does a gynec patient needs to be referred to an assisted reproductive technology center?
In the current ART law, I would like all of you to prepare yourself to be registered as an ART level 1 center. Why should you refer your cases to an ART2 center? That is my straightforward question to you. Because referring your cases to an ART2 center, the same gonadotrophins you can apply and you can do. Because after all, you should actually start, working on it, that you are able to use the gonadotrophins. After all, you are all MDs and you should do it. And I have also said that I have started this online program of Medline, where people actually can do it online only and get registered. It is also university recognized, because I find it very difficult to understand you people who are all MDs and you have done so well in your practice. If you say for endoscopy also I cannot do. If you say that MTP also I need to go and get registered, and then for ART also I need to get registered, for genetics also I need to get, then what are you people going to do? Are you a distribution center? No. What, Charvila?
Yes, ma'am.
You should be able to do endoscopy. You should be able to do this thing, IUIs and all that. And you register yourself boldly. What do you say, Jem?
Madam, unmute yourself, ma'am.
Yes, Kamini, this is how we learned in 1980 to 1990. Before all these people started, all these endoscopists, ART people, all those things. We learned by ourselves. We had a big ultrasound probe, abdominal probe. We looked at kidney, uterus, everything by ourselves. But nowadays, the government itself says, if it is a NT scan or target scan, send it to a fetal medicine expert. If endoscopy,
only fetal medicine people. No, that is not right.
So
that
many
is why I am
persons are threatening gynecologists in that second level, third level units. That is the problem.
That's okay. So that is why I am telling you, gynecologists don't need to refer to ART. You become that center. That is all I'm trying to tell you.
Yes.
It's a good idea.
Yes,
Why
ma'am.
should you refer?
Yes. And
You're
one more
not
question.
in an emergency room where you send it to different things in a hospital. Yeah, you people be that department. That's all.
And suppose a patient has got galactoria, will you do a prolactin estimation, or you will just treat her with galactoria?
Suppose now she has galactoria, I will see first, are you pressing the nipple and then getting the fluid, or is that fluid coming without pressing the nipple? See, many times nipple stimulation itself gets some amount of serous fluid. What I would suggest is make sure you see the thyroid first. If the thyroid is high and prolactin is borderline high, I will treat the thyroid first. Yes, I won't treat the prolactin. Now, just because you've got a borderline prolactin high, it doesn't necessarily mean you have to treat. If the thyroid is treated, the prolactin corrects itself. Secondly, if you are going to squeeze, I'm sure any one of us sit and keep on squeezing, there always is going to be some fluid coming. Because many times that kind of sensation when you keep on squeezing, one, it causes pain, and two, it will get a serious discharge. And then what happens is they get scared. So just ask them not to squeeze. Make sure if these people are on any antipsychotic or antipsychiatric drugs, make sure if there are any medication that will increase. Also, if they have been under stress, that also increases the prolactin. First, make sure naturally, is there anything that is increasing the prolactin? Simply because there is one level of prolactin that is high, don't dump them as hyperprolactinemia. You have to make sure that what is the triggering factor for prolactin, and then only decide.
Decide. At what
Because I
time of
know people,
yes.
and tripole serum is what you would do. And there is diurnal variation of prolactin. And if you take the prolactin in the morning, that will be best. Not, when they've, sort of come in the afternoon or evening, whatever. The early morning specimen, empty stomach is what I would expect. And that too, if you put in a butterfly needle and then leave it there half an hour or apart, 3 samples collected. Okay.
Yes, ma'am.
Then you then mix it, do your prolactin. But
Okay.
people don't have the time to, you understand? And because it's like a sawtooth appearance, I don't want you to have a knee-jerk reaction in doing the prolactin levels and treating them.
Okay. And is testing for luteal progesterone mandatory in any patient?
No.
What will make you do a luteal progesterone level? Any indication for that?
What will make me, if I have that kit over there, I'll do it. If I don't have that kit,
Okay.
I will have the ultrasound.
Okay.
See, the ultrasound itself, if you look at the endometrium, that endometrium will anyway, the progestinization of the endometrium, the thick endometrium, absent that midline, and also you will see a corpus luteum in the ovary. And also if you see that there is fluid in the pelvis, these are all telltale signs of ovulation. But if in case you're still not able to see whether that ovulation has occurred or not, then perhaps if you have access to the progesterone, then you take that, the sample and can do that progesterone test. And think about 3 nanograms per ml done on day 21 of the cycle. Then you can go ahead and do it. Particularly if this woman has not come on the 2nd day of the period, she has not come on the 15th day of the period or 12th day of the period, she just bang on comes on the 21st day of the period, and you see on the scan, you've not followed the follicle, nothing. But if even then, if you see on the scan a very secretory endometrium, that itself will tell you that she's progestinized. So to say that if you don't have serum progesterone, you can't do infertility, that is very far from the truth.
And for a youngster, which will be the ideal procedure for the tubal patency? Hysterosalpingogram or sonosalpingogram?
HSG is good enough. No, HSG is good enough, and I think you people should take care that the woman does not have pain. See, many of you just go in and shove that catheter inside and just push it in. Please understand, many times you will have those bilateral coronal spasms and then blocks. Please do give some amount of antispasmodics and then do it adequately. Be humane. Don't be in a hurry. Okay, that is the worst thing. Most people come and complain to me. I'll never go through that HSG. It should be a very pleasant, or you can do fluoroscopy. That is also fine. But the reason many people go and do it is because they give it to that radiologist or a radiographer. That is not right.
Yes.
I think you people should do it. And if you do it, then using a C-arm, if you do a fluoroscopy, that also is fine. Or sonosalpingogram, yes, you can do it. No problem at all. It depends on how expert you are and the available equipment you have. So there is no, gospel truth that this is what you can do and this is the only thing that you can do. Basic evaluation is good enough. What you can charge less for the patient is good enough. And that is all that I can tell you.
Yes. Thank you, ma'am. And this last question is a role of pentoxifillin in adenomyosis.
In?
Adenomyosis.
No, I think this was actually an experiment people did. Earlier, they did it for the sperms to see that they keep moving faster and all that. But that was like a little burst of energy, a little bit of Viagra for the sperms. But it didn't really make a difference. And even petoxyphylline for adenomyosis, it gained a little bit of, what do you say, importance, but it died down. So, no, it is cheap, no doubt, but they've also used it in the sperm preps with very low motility, and they have claimed anecdotal successes. But insofar as adenomyosis, no.
Okay. Thank you so
Not
much,
at
ma'am.
all.
Yeah, thank you so much,
Okay.
ma'am. There are no other questions. Thank you so much for your inputs, ma'am. It was extremely useful for all of us. May I request Dr. Shanti
Thanks.
Venkatakrishnan, the president, to thank madam, and we'll go on to the next talk.
Sure.
Dr. Shanti? Shanti, you have to unmute her. She's
Yeah,
from
yeah.
Mayavaram, madam, deep south. She's from Mayavaram. That is.
Yeah.
Pandian sir has joined.
Sir
has
I know.
joined.
We are
Vanakkam.
Vanakkam, sir. Vanakkam, sir. Vanakkam.
Everybody, Vanakkam, Namaste.
Vanakkam, vanakkam.
Thank you so much, Dr. Pandian, sir, for joining. We'll go on to the next talk. After one stalwart, a legend, we're going on to the next legend, and he's going to talk on male infertility. May I have his CV, Shakisagiti?
No, let Shanti finish her
Yeah.
remarks.
Yeah,
Shanti?
yes,
Shanti,
ma'am.
concluding.
Yeah, yes. Ma'am, your presentation was very nice, madam, and you told the practical points and from the practice point of view, not the routine academics. And there are, especially the hyperprolactinemia approach was something exciting and new. What we were routinely doing, you said that thyroid should be evaluated first. I think this will be very useful for the practitioners. And I want to remember one more thing, madam. You came to Bellary in 1995. I was doing my MD in Bellary Medical College, Government Medical College. You gave an excellent talk that day. One assistant asked about certain procedure that he was doing some heroic stride. You said you may succeed in 99, but in 100th case, you will get into trouble. That always flashed in my mind, especially when we do practice, no medicine practice, it should practice within that boundaries, within that ethics, within that protocol. That always should be in the mind of youngsters. Thank you, ma'am. I still remember you. I don't know whether you remember us in Bellary. Thank you.
Thank you. Thank you.
Thank you so much, Shanti. May I now have the CV of Pandian, sir, please? Professor Pandian Nadarajan, sir, is a chief consultant in andrology and reproductive services, Apollo 24/7, Nova IVF Fertility, Chettinad Super Speciality Hospital, from which he's retired. He's a professor emeritus of the Tamil Nadu Dr. MGR Medical University. He's got a very strong record of clinical and basic research, which is focused in embryology and andrology, which includes transferrin production dynamics in Sertoli cells, GnRH pulsatile infusion in hypogonadotropic hypogonadism. Sir has got innumerable publications in various index journals. He's got almost 4 decades of teaching experience, which includes mentoring of 5 PhD students and more than 50 postgraduate diploma and fellowship students in andrology, embryology, and reproductive medicine. He's got the Lifetime Achievement Award by the Tamil Nadu Dr. MGR Medical University, Chennai, India in 2012. He's a founder editor of the Journal of Reproductive Biomedicine Online, along with Professor Robert J. Edwards, who's a Nobel laureate, and as the founder and chief editor from 2000 to till date. And Sir has served in the ICMR National Committee to draft guidelines for assisted reproduction in India in 2005. So your CV was almost like running in pages. I had to reduce it because we want to listen to your talk and we want to learn from you. Thank you, Pandian sir, for joining from States to take out your precious time early in the morning. Thank you so much for joining with us, sir.
Vanakkam, Namaste, and good evening to all of you. It's nice to catch up with my, I would say, former friends. I won't say old friends. Former friends, Jayam, Kamini, and so many other people, and also with young people. I always enjoy interacting with people. So let me just start my first slide. And am I made a host now to share the slides?
Yes, sir.
Yes.
No, not yet.
It'll take a little time, sir. 1 or 2.
Okay.
Yes, sir. It's seen now.
You can see now. Okay.
Yes, sir. And you have to make it a full screen, please.
I can't see it yet. Maybe what's the problem?
It will come, sir. 1 or 2 minutes.
Pandian speed is something jet speed.
I'm
But
sorry, I'll slow down.
Regular speed.
I'll slow down. You see, there is a problem.
I still
Sharing.
fondly remember our days of attending the meetings in 90s.
Yes.
Yes.
Can you all see the slides now?
Yes, sir. Yes, yes.
Okay.
Yes, sir.
Please slow me down if I'm going too fast.
Okay, sir. Yes.
Yeah, this is the current trend. People keep saying that fertility is declining, infertility is increasing. I'm not sure how many of you favor this thought and idea. Somehow I have little reservations about this. The data is not very convincing that fertility is declining or infertility is increasing. You will see during the course of my talk why I am stating this. They look counterintuitive. If one is declining, other should increase. But we have no data for that. All I'm saying is I do not know. And we do not know for sure whether it's really true. But the definition of infertility itself is a little doubtful. The classical definition is 1 year of regular unprotected intercourse. But strangely, no definition, there are different definitions of infertility, but none of them ever define what is regular. And that makes a huge difference. If it's once a week, once a month, for the couple, it's all regular. We tend to believe that once a month is not adequate. We know that it's not adequate for conception, but for the couple, it's a regular intercourse. Regular means at a regular interval, that's all. So we need to have a clear definition what we mean by regular. And the definition again is it 1 year or 2 years? NICE would say 2 years. Some people would say 1 year. And does this 1 year apply to all ages is a question we need to raise. And in fact, we recently had a paper on this topic on infertility, what do we really mean? Again, the incidents, you find different books and journals keep quoting different incidences. And unfortunately, most of them are based on data which is very, very old. So please go back and look at your own data. Just take the last 100 cases, couple who came to your clinic. I'm sure you will find the incidences so different from what has been quoted in textbooks. Even this data from UK clearly tells you male factor is only 30%. People keep saying that male and female have equal contribution to an infertility. In fact, the equal contribution does not come here. You will find, this is the incidence from our own department. You find that the most important cause of male infertility itself is unexplained. By unexplained, what happens really is the age of marriage and the age of childbearing has been postponed for so many reasons. That contributes to the infertility. Remember, infertility and fertility are dependent on the age of the couple. It's a race against time. The longer you delay, worse the prognosis and greater the incidence of infertility. So female factor is 35%. Male factor, remember, ours is a tertiary referral center. Yet it was only 16.8%. The couple factor was in 10%. The classical teaching would be 40-40-20 or 30-30-30 and 10, indicating male, female, and that's not true. The reason is we don't have to keep quoting that. We have to go back to your data and find. You will find definitely the data is different. I can tell you that for sure. This tells you why we have a lot of azoospermia, because ours is a tertiary referral center for male infertility. So you find predominantly, if you take male infertility, azoospermia was the commonest reason why they refer the patient to us. And remember, human fertility is a composite effect of the woman's fertility and the male partner's fertility. It's not a standalone. Only in azoospermia and bilateral tubal block, it's an absolute factor for infertility. In all others, it's subfertility, and one person's subfertility can be compensated by the other person's superfertility. This slide depicts exactly what I meant by that. If they both are normal, whatever we define normal as, then they conceive in a short time, maybe in a few months' time. If one has got a problem, man has got a little low concentration and low motility, the woman is young and she's ovulating regularly, they again conceive, they don't come to us. That equally applies for the woman having a little irregular cycles, yet ovulating, they would conceive. These people don't come to us at all. They probably come to you for pregnancy care. When they both have a problem, the woman has got irregular cycles, the man has got very low concentration and motility, they land up with us. That's the group we are trying to attempt to treat. A few words about normal fertility. Remember, most of infertility is genetics. We need both arms of the Y chromosome. The short arm carries the SRY region, which is essential for gonadal development. The long arm carries the AZF, A, B, and C, which is essential for spermatogenesis. SRY is crucial for gonadal formation, and microdeletion in the Y chromosome can't produce non-obstructive azoospermia and severe oligozoospermia. Analysis in the deletions A, B, and C may lead to impaired sperm production. Besides the long arm and the short arm, there are several other genes involved in spermatogenesis. Both may be normal. The other genes involved in spermatogenesis, and that can contribute to impaired sperm production. That gives you a very brief idea about endocrinology. The GnRH from the hypothalamus acts on the pituitary to produce FSH and LH. LH acts on Leydig cells to produce testosterone. FSH acts on the Sertoli cells to help it produce aid in spermatogenesis. Sertoli cells in turn produce inhibin, which produces feedback suppression of FSH. Testosterone produced by Leydig cell leads to feedback suppression of LH. This gives you further details. The testosterone produced by the Leydig cells goes into the circulation and also diffuses into the Sertoli cells. Sertoli cells produce androgen binding protein, and that carries the testosterone into the intraluminal compartment. This is a very crucial point. The intraluminal concentration of testosterone is 50 times the plasma concentration. This cannot be mimicked by pharmacotherapy. On the other hand, if you give testosterone to a man with male infertility, you will do a negative suppression or negative feedback, lead to suppression, and you may even produce azoospermia. The important message is testosterone therapy is not advocated for a man with infertility. Well, when we call a man as infertile, if the partner is not pregnant, if he's not able to perform, and if the semen analysis is abnormal. What is abnormal? We will see in a minute. He is infertile if he is not able to perform the sexual act, if he has erectile dysfunction. He is unable to ejaculate, ejaculating dysfunction. Or if he ejaculates, but the ejaculate goes back into the bladder, what we call as aspermia. These men have sense of ejaculation, they achieve orgasm, but nothing comes out. Or if he is able to perform, ejaculate, the ejaculate is inadequate. I would like to start by saying that an evaluation of an infertile male starts with counseling. If he's got a problem, he needs a lot more counseling. If he doesn't have a problem, he needs counseling not to harass his wife. Very, very important, because his ego is bruised when he's got a problem and he needs counseling. Many of you may not see, I see many men crying in the clinic. So it's important you counsel him and start your program. And when you start taking history, it's very, very important we do what is called active listening. Most of us have the habit of interrupting a patient, or we have a proforma. Proforma is fine so that we don't forget any important point. Nevertheless, we also need to listen to them, give their history. Some of them may get carried away and go on for a longer time. We need to know when to stop, at the same time listen to them actively. Clinical examination is crucial even in this era of ICSI. Investigation in relevant patients, management, and alternatives that we discussed. Well, I would like to emphasize history, very, very important. The man may have no problem at the moment, but he might have had an undescended testis fixed in his childhood. Again, you should ask when exactly this was done. If it has been done late in his childhood, that may not help in restoring fertility. Infection, both in adult life and childhood, inguinal scrotal surgeries, hypoandrogenization features, sexually transmitted diseases can lead to blocks, testicular trauma, torsion, hormone supplements. He may look androgenized. We have had many patients coming like that. He looks androgenized, then you realize his androgenization is because of exogenous hormones. In many couples, when they start their married life, they use lubricants. And they continue to use lubricants. As all of you know, lubricants are spermicidal or spermicidal, and they're not good for fertility. So you must ask for history and ask them to stop it. Ask for history of libido, erectile and ejaculatory dysfunction, and current medication. Many young people today are on medications. They are on PPI inhibitor, or they are on antihypertensives. Some of them are for cholesterol, anti-cholesterol drugs, statins. All of them impaired with fertility or sexual function. Therefore, ask a history of medication, and also for medical illnesses. And again, very important is to ask for history of smoking, alcohol, and drug abuse. Well, clinical examination, evaluate the height, weight, and androgenization. Look for evidence of gynecomastia, inguinal scrotal scar, and physically examine the penis for evidence of hypospadias or epispadias. This could just be the cause of infertility, is depositing the semen in the wrong place. Scrotum for the presence or absence of testes, again, we need to examine for that. Palpate the neck of the scrotum for the presence of vas deferens, and feel the epididymis or nodularity of the epididymis, which can indicate epididymal blockage. Semen analysis is the single most important test. People keep saying it's inadequate. It is inadequate. Yet, that's the most important test. Properly done semen test with proper instruction will give you enough information. If it's abnormal, only if it's abnormal, we need to do further investigation like FSH, LH, prolactin, testosterone. These are all indicated only in selected cases. Again, karyotype and Y chromosome analysis in selected cases, particularly in men with azoospermia and severe oligoasteroteratospermia. Spermatozoa function tests they are not useful. It's a rote and over. In fact, every decade you find a new test coming up. When we were all training to sperm cervical mucous interaction, WHO published a manual on that. And we were going through that process. Then amsteric penetration test. Every decade you find a new test. The current decade has DNA fragmentation tests. But these tests are not useful. They do not give you any additional information. They only cause more confusion. Well, this is what Anton von Leeuwenhoek described in 1677. And remember, he is not a doctor. He is not a scientist. He's a linen maker. And his fascination was making lens. With that, he looked at the sample, and this is what he described. We have not done any better than that. Today, we find that this still applies true. Semen analysis, despite all its limitations, remains the only test which has stood the test of time for male fertility. 7 parameters: concentration, motility, and morphology. They all have poor positive and negative predictive value, particularly morphology. Today, many centers have given up doing morphology evaluation, except in extremes. If it's all pinhead, if it's all amorphous head, rounded, it's a different story. Otherwise, going to the hair splitting of tail defect, this defect doesn't really matter. And there's no count below which spontaneous pregnancy is not possible, except azoospermia, and no count above which pregnancy is certain. Yet, several tests have been coming in, and these tests, which came to supplement or complement semen tests, have caused more confusion than clarity. But remember, semen analysis is inherently variable. All the parameters keep changing from time to time. And the main factor which determines a man's sperm count is the number of Sertoli cells in his testis. And this is fixed early in development. By adulthood, the final number is determined, and no further development is possible. Therefore, you really can't do much to improve his sperm picture. Look at the WHO manual, which changed from 1980, the first manual, to 2021. Not only the color changed, the content also changed. And many men considered to be infertile before have now become fertile, because we are slowly understanding. We have been overdoing this and calling a lot of men as infertile. And see, the major change has been between 1999 and 2010. 2010 and 2021 are not hugely different. This you see fine, particularly in morphology. The huge drop from 14% to 4%, and that also applies to concentration. So we find that the sperm parameters, as we understand today, is given in the last column. This is again the reference value, and the fifth percentile value, which means there are still 5% of men who achieve a pregnancy with sperm concentration less than this. And this is a 20th century phenomenon. Remember, semen analysis and now a numbers game. And sometimes we do too much of reading into it. At 12 million and 14 million doesn't make a difference. Patients often worry about it. All they need is reassurance. Patients should be told that the total count is what matters and not what is there in per ml. This is again from WHO. This is like you may remember in your younger days, we read in medical school what is called irregular pulse. There's something like that, like out of the stock market. You see the huge variation in sperm count from time to time. It sometimes drops even to near azoospermia. The important lesson is, do not judge a man's fertility based on a single sperm test. You need to repeat it again. And also, if it's abnormal, investigate further, and also clinical examination to correlate the findings. This is our own department data. You see what has happened. This is still 2009. Normal zoospermia was only 6.7. The patient population did not change. After the WHO new manual came, we find 45% of them are normal, which really clears that fertility is not declining if you go by WHO standards. Look at this. Almost all the important parameters indicate that there's a decline in infertility. This is the important thing. The important point I want to say is, go back to look at your own record, and this 30, 30, 30, 10, or 40, 40, 20, they're all not true anymore. You find a male's contribution is important. He really contributes to an infertile marriage, but it is not as common as is being depicted. What is the commonest reason today is unexplained infertility. But this tells you the distribution of, again, nobody's clear how did they arrive at 39 million. 1.5 into 15 will be only 22.5. These are not very clear pictures. And remember, we call a man as infertile based on his semen picture. If semen picture is reasonably normal, we call him as normospermia. If it's abnormal, we call it as oligozoospermia. What is abnormal is again a little confusing. Is it less than 14 million as per the current WHO standard? Or is it less than 39 million they ejaculate? Nobody's sure. I, for one, I do not worry about 39 million because 39 million is not based on data. I would go with the total sperm, which will be 14 million into 1.4 ml. That's the 50% value, which comes to something like 19.6. So if 20 million is the total sperm concentration, motility, count, then that's good enough. Anything less than double oligospermia, but that may not be the cause of infertility. As you know, zoospermia has a reduced sperm movement. Teratozoospermia has less than 4% normal sperm, or more than 97% abnormal sperm. This again has become very irrelevant to these days, unless it's all 100% abnormal. Oligoactinoteratozoospermia is all of them being a combination of all the three: low concentration, low motility, and more abnormal sperms. Aspermia must be differentiated from azoospermia. Aspermia is absence of ejaculate. No semen comes out. Azoospermia is semen is present, but there is no spermatozoa in that. Cryptozoospermia, we'll see that is some sperma present in the centrifuge. Again, I want to re-emphasize, clinical examination is important. Check whether the man is androgenized. Is the urethral orifice in the right place? The testis size is normal. The testis is at firm in consistency, and he has a sensation. Feel for the vas deferens. Examine the epididymis for evidence of distension, and examine the varicose for the presence. You record the presence of varicocele, but don't take any action, because if you miss it, somebody may complain he missed a varicocele. And you must examine for varicocele in the erect standing posture with the man doing Valsalva's maneuver to confirm the presence or absence of varicocele. If the semen analysis is abnormal, repeat the semen test. If it's normal in your own lab, which you have confidence, then you need not repeat the semen test immediately. But remember, if you had a semen test more than a year or more than 6 months, you may have to repeat it to confirm that it remains the same. If it's abnormal, then you proceed for further investigation like follicle stimulating hormone, semen culture, if the leucoscreen shows leukocytospermia. But this is again data from our own department. Just the mere presence of leukocytospermia does not indicate infection. That is an earlier belief. Today, you need to do a culture, and the culture shows positive growth, then you need to put the patient on appropriate antibiotics. And that should be given for a longer period, at least 2 to 3 weeks, and not a short course. FSH again is crucial. Remember, this again from our own department data. You find in men with normal semen picture, the FSH is around 6.9. In men with oligozoospermia, the FSH is around 11.4. In obstructive azoospermia, it's 5.3. And in non-obstructive azoospermia and severe oligozoospermia, you find it's a 30. This is data. You find the reference values given by most of the labs or the kit would be wrong. They give up to 14 is normal, 14 is not normal. These are the values you find. In fact, the American Society of Urology also has recently redefined the normal parameters. What is important, as I mentioned before, the total motile sperm count in the semen sample. This we obtain by multiplying the volume into the concentration and the motility. Morphology can be ignored as of now, except in extremes. It is important to understand that what is important is the total sperm count in the ejaculate. The evidence for use of antioxidants is very, very limited. The treatment options would be IUI, IVF is questionable, ICSI. The National Institute of Clinical Excellence, UK, went one step further and said, don't even do IUI. Straight away, ask the couple to wait for 2 years, and if they're not pregnant, take them up for IVF. And their recommendation would be the semen sample has got 10 million spermatozoa per ml and 30% are motile. I mean, these are recommendations. You could follow your own guidelines. And we also want to emphasize that if you're judging a sample just on one look at the semen sample, that's not adequate. You may find immotile spermatozoa on the first look. The same spermatozoa may start moving after some time. So please relook at it and judge it based on these 2-3, look at the different areas of the sample, the same area on 2-3 occasions. This is again data from our own department. You see, concentration and motility keeps changing from time to time. This is the same man, proven fertile man. How much his picture varies from time to time. The concentration varies and the motility also varies. And there are some men who have absolute acinospermia. That is, there is not a single sperm moving in his ejaculate. First, exclude an artifact. Some of them a problem in collection. I have had men who collected with condom before they came to us, and all the previous reports showed all dead spermatozoa. So this must be differentiated. Asthenospermia is live spermatozoa, but not moving. Necro is all dead spermatozoa. I have never seen a true case of necrospermia, all dead spermatozoa. If it's all immotile spermatozoa, a vitality test will show you whether it's alive or dead. The treatment will be, again, ICSI. And this shows you the different abnormalities. You really don't require such hair splitting of the different abnormalities today. Sperm morphology has very poor sensitivity and specificity in the diagnosis of infertility. The very little clinical value, and today we do not lay much emphasis on this. Another area of controversy is varicocele. I was doing a lot of varicocelectomy in the past, and I woke up one day and I started looking at the data and find that many data today clearly indicate that varicocelectomy is not useful. The Association of Urologists also have come to the conclusion, you have nothing better to do, you may consider doing it. Even that I would not recommend, because you're wasting the patient's time, and time is a crucial element. As I keep saying, infertility is a race against time. So don't waste time, straight away refer the patient. If you're a urologist, refer the patient to your colleague, gynecologist who does infertility. and the patient is better off depending on the semen sample with IUI or IVF. A lot of theories proposed for varicocele. One, they started with temperature, they said adrenal metabolites. Now they're talking about DNA fragmentation. All these are not really indicators of varicocele producing problem. The NICE is very explicit about it. Men should not be offered surgery for varicocele as a form of fertility treatment because it does not improve pregnancy rates. And remember, oligozoospermia is not an isolated condition. It's often associated with actinozoospermia and keratozoospermia. The most common cause of male infertility, if you look at the sample, OIT is diagnosed only after repeat analysis and relevant investigations. Conventional IVF's no role in male infertility. ICSI is a treatment of choice. Either you do IUI, or IUI is not successful, take the patient for ICSI. Medical management has very little role. We'll see in a minute what is the role of medical management. Medical management is indicated only in patients with hypogonadotrophic hypogonadism. In men with sexual dysfunction, if that contributes to infertility, yes. In associated medical conditions like hypothyroidism, hyperprolactinemia, you may put the patient on medication. In all other conditions, medicine is of very limited value, or I would even say no value at all. In hypogonadotrophic hypogonadism, patients should be put on pulsatile therapy. That's not practical, so we put them on gonadotrophins. In hyperprolactinemia is either bromocriptine or cabergoline. In genital tract infections, if you demonstrate culture-grown organism, then put the patient on appropriate antibiotic. In retrograde ejaculation, people have tried imipramine. I have no experience. I try what is called as sperm retrieval from the bladder, which you will see in a minute. In erectile dysfunction, you could try whatever drug, what are the 3 drugs, whichever the patient is comfortable. Again, medical management, in the past we used a lot of drugs. Today, the current fashion is use antioxidants or nutraceuticals based on some misinterpretation of physiology. And we do not believe any of these drugs help at all, based on our own experience. They're all of unproven value. And the Association of Urologists also is very clear. Medical treatment of male infertility is recommended only for cases of hypogonadotrophic hypogonadism. And antibiotics should be given for a longer period if it's prone in infection. A word about antioxidants. Remember, reactive oxygen species are natural occurrence in the body. They are a product of metabolism. They are present in every tissue. And they're also physiological cue for apoptosis. And people do DNA fragmentation tests and try to interpret that as more of oxidative damage and they push the patient on antioxidants. There is no convincing evidence to say that this is useful and it improves fertility. And the claim has been it improves concentration, motility, and morphology, all of which have not been proven by different studies. So to touch upon the management of oligozoospermia, if it's mild, you could wait for a couple of months, the couple are young. Otherwise, the treatment would be controlled ovarian hyperstimulation and intrauterine insemination. If it's moderate, you can try IUI again if the couple are young or proceed to ICSI. Severe requires ICSI. Azoospermia, if you're doing surgical sperm retrieval, again, ICSI is a treatment of choice. Remember, human being could never fly despite innumerable efforts. We invented the aeroplane. As science stands today, a man's sperm quality is variable and mostly cannot be improved. Luckily, there are enough techniques to help a man achieve a pregnancy without indulging in unproven therapies and wasting the couple's time. The take-home message I want to give on this part of the study is oligoacinotetraspermia cannot be treated by medical or surgical measures. We need to learn to manage with available spermatozoa and do the best possible. Drugs or surgery do not have any role in treating oligoacinotetraspermia. Let's just now move on to azoospermia. As I said before, not one look at the semen sample and say it's azoospermia. You need to centrifuge the sample and resuspend the semen sample pellet and confirm it's azoospermia. If after resuspension you find some spermatozoa, then that would be cryptozoospermia and not azoospermia. The incidence in our department is 10.09%. And the obstruction, in obstructive azoospermia, the obstruction could be at different levels. It could be at the ejaculatory duct, the vasal obstruction as in vasectomy, or the vas could be absent from birth, the congenital bilateral absence of vas deferens, or it could be an obstruction of the epididymis, or there could be an intratesticular obstruction, which is very rare. I've never seen a case of intratesticular obstruction. Non-obstructive azoospermia could be due to hypogonadotrophic hypogonadism, seminiferous tubular failure, or what we described in 1899 as borderline azoospermia, what is currently called as maturation errors or cetulicid-only syndrome or hypospermatogenesis. This gives you a diagnostic algorithm. All men with obstructive azoospermia have normal FSH, which is in our own data is around 5, 6, around that. All men with obstructive azoospermia have normal sized testes. Most men with obstructive azoospermia have normal semen volume because testes contributes only to 5% of semen volume, and they have fructose present in the semen sample. Only 2 groups of men do not have fructose in the semen sample. Low volume semen sample, azoospermia, fructose absent, indicates either ejaculatory duct obstruction or absence of vas deferens. So if you find a man with low volume, absent fructose, consider these 2 things. Clinical examination will show you clearly that this man doesn't have a vas deferens. This man with ejaculatory duct obstruction has a typical history of painful attempt at ejaculation, but nothing comes out, or only a drop comes out. Men with non-obstructive azoospermia, hypogonadotrophic hypogonadism men have low or undetectable FSH. They also have low LH, low testosterone, and normal prolactin. Their testis size is small. It's an unstimulated testis. If they manage to collect a semen sample, the volume could be normal. They have additional features like hypoosmia or anosmia if it's Kalman syndrome. Seminiferous tubular failure, the FSH is raised, testis size is small, semen volume is normal. In borderline azoospermia, the histology is often maturation arrest or hypospermatogenesis. They have normal to mild elevation, testis size is normal or slightly small, normal semen volume. Aspermia is ejaculatory failure. These men have good erection, but they fail to ejaculate. In retrograde ejaculation, they have good erection, they have sense of ejaculation, they get orgasm, but ejaculate goes back into the bladder. Sorry. In erector and ejaculatory failure, they have neither good erection nor ejaculation. Spermatozoa function test, as I mentioned before, every decade you find a new test being introduced. Most of them have died a natural death. Hypoosmotic spelling test is useful in identifying a viable sperm. All other tests are of only historical importance or research importance. A word about surgical correction of obstructive azoospermia. The man has had a vasectomy. A vasovasostomy is very effective. Sometimes this is not adequate. You may have to do a vasoepididymal anastomosis. Vasoepididymal anastomosis is indicated when there's an obstruction of the epididymis, and also in a vasectomy reversal. At reversal, you find there's no spermatozoa in the proximal end. This man has got an epididymal blowout. So vasovasostomy and vasoepididymal anastomosis are indicated in men with obstructive azoospermia. Where you do the anastomosis, in vasectomy, you do a vasovasostomy if you can find spermatozoa in the proximal end. Otherwise, you do a vasoepididymal anastomosis. The sperm retrieval techniques are come to stand today. Most clinics practicing infertility today have to become conversant with this. You find many different techniques have been introduced at different times. Today, we find if a good ICSI program is there, all you need is to be able to put a needle into the testis or the epididymis in obstructive azoospermia, and you'll be able to recover spermatozoa. In non-obstructive, putting a needle into the testis alone is not good enough. You need to do an open biopsy, multiple biopsy, and recover sperm. This is MISA, microepididymal sperm aspiration. That gives you, if you're a microsurgeon or if you have some access to a microsurgeon, that gives you the best quality spermatozoa. You'll find sometimes the ejaculate is like a prepared semen sample, and that is suitable for all techniques. However, of course, we use only ICSI for sperm obtained from sperm retrieval. In macro, all gynecols can be trained in it. You open again and you look under the with your naked eye and aspirate from the epidermis. This sample is adequate for ICSI. And this is PISA. PISA is the simplest of all techniques. All gynecols can be trained if you don't have a urologist to help you. This is very easy, but it requires, again, a little bit of training. And you put a needle through the skin and aspirate. Of course, you need somebody to stabilize these testes, stabilize the epidermis, put a needle, use a butterfly needle or an insulin syringe needle and aspirate. And in obstructive azoospermia, you'll get adequate spermatozoa for ICSI procedures. And all these techniques are interchangeable. Whether you do MISA, ASA, or PISA, all these techniques will give you adequate spermatozoa for ICSI in men with obstructive. I want to re-emphasize because putting a needle in a man with non-obstructive azoospermia will lead to damage, and you will not get spermatozoa. In obstructive azoospermia, you will get spermatozoa by all these methods. In men with ejaculatory failure, we have had one case. This is not common practice now. You can even aspirate sperm from the vas, and that will also give you adequate spermatozoa. Today, with the technique of sperm retrieval from the testis, you really don't require vasal sperm aspiration. And this is important. In men with retrograde ejaculation, you can recover sperm from the bladder without any intervention or invasive procedures. Why a man has retrograde ejaculation? It could be because of autonomic dysfunction, an abnormal ejaculatory duct, or post-prostatectomy, damage to the sphincter, or it could be idiopathic. Well, there are different methods described in the literature. Some of them are very anesthetic, like what you see in the slide. We will not go into the details. What is important is the last technique, sperm retrieval from the bladder. Again, this has been done by putting catheterization. All that's not required anymore. The problem in retrograde ejaculation is the ejaculate goes back into the bladder. The acidic urine kills the spermatozoa. So you need to minimize the contact of the spermatozoa with the urine by recovering the spermatozoa from the bladder. So what we do is we ask the man to void urine. This leaves only a very small amount of urine in the bladder. The man is now asked to masturbate and have intercourse and achieve an orgasm. At orgasm, the spermatozoa are ejaculated and go back into the bladder. The spermatozoa now come in contact with only a very small volume, and now you can ask the man to void, and you collect it in a large volume of buffer. This 20 ml buffer will neutralize the acidity of the urine. Now, from this large volume, you centrifuge and obtain spermatozoa and use it for preferably assisted reproduction. We have even tried IUI and have been successful. This is a very old data when I was working in Apollo. Subsequent to that, we have some more pregnancies. This is a recent publication on this. And sperm retrieval from the testis is a very simple technique. All you need is to do an open and take a biopsy. Any surgeon can be trained, any gynecologist can be trained to do it. The important message is you need to take it from mother. A true cut biopsy is not adequate. It's okay for a man with normal spermatogenesis. In a man with non-obstructive azoospermia, you need to take multiple bits from multiple sites. This is based on the pathology. Men with non-obstructive azoospermia, if they have foci or spermatogenesis, it is not in the equatorial plane. This is what the micro-tissue group people do. They cut in the equatorial plane and try to obtain spermatozoa from the tubule around that. It could be somewhere there. So a biopsy in different parts of the testis. We take 3 bits from 3 different areas, depending on the size of the testis. So it is important you take multiple bits from multiple areas. This definitely reduces the testicular volume, but it does not really affect his sexual function in the long term. Besides that, some men also have malignancy. So if you're going to take a biopsy only in the equatorial plane, you may miss a malignancy. So my strong recommendation would be to go for multiple bits from multiple sites rather than go for a micro-tissue in the equatorial plane. Micro-tissue is the talk of the town today. Wherever you go, people claim it's better than the conventional, but they compare with the conventional single-site biopsy. The important thing is to compare it with multiple site biopsy. I would feel that it would be the same. The results can't be different. The problem with micro-tissue, it's time consuming. We did a few cases and found that it's not useful and gave it up. It requires microsurgical expertise, takes much longer and more expensive. The big advantage is it removes much less testicular parenchyma. I'm not convinced it's superior, and it does not conform to the known pathophysiology of non-obstructive azoospermia. And we can miss a malignancy if it's present. And it's people who are doing microdissection also claim it's not very useful in maturation arrest. And that shows you microdissection. You see the difference? You find you remove only a small portion of microdissection as you remove a larger portion. That's the claim. And I also checked with the embryologists who check on the sample. They said even from a dilated tubule and opaque tubule, they sometimes don't find spermatozoa. As I mentioned before, fine needle aspiration is the simplest of all techniques in sperm retrieval. The spermatozoa are directly aspirated from the testes using a syringe and fine needle. I want to re-emphasize that this is not suitable for non-obstructive azoospermia. It is suitable only in cases with obstructive azoospermia. It will give you adequate spermatozoa, and it will not give spermatozoa in non-obstructive. That shows you the technique of fine needle aspiration. Whether to use, I would recommend using anesthesia even for this, because it's a painful procedure and you may do it 2-3 times if you don't get spermatozoa. So don't attempt doing it without adequate anesthesia. And these are our own data. We've had 47 patients, 19 were non-obstructive, 28 were obstructive. For some obstructive is also we need to go and do testicular sperm collection because epididymis was fibrosed. And we have had 14 pregnancies. And the important point I want to emphasize on this data is fertilization and cleavage rate and pregnancy rate were the same, regardless whether it's testicular spermatozoa or epididymal spermatozoa. Regardless of the source, it's the same. Again, it's the same whether it's non-obstructive or obstructive. Fertilization, cleavage rate, and pregnancy rate in our series are the same, regardless whether it's non-obstructive or obstructive. And whether it's frozen or fresh, this again is used to be a debate, whether you should use frozen or fresh, whether you use frozen spermatozoa or fresh spermatozoa. Again, fertilization, cleavage, and pregnancy rate are the same in our own series. And this series has become wider now. We had 53 patients with non-obstructive azoospermia. In 21 of them, that's nearly 40%, we were able to recover spermatozoa, and 4 of them achieved a pregnancy. To give you summarize the whole thing and give a flow chart, semen analysis remains a crucial test. If it's abnormal, if it's oligozoospermia, consider doing intrauterine insemination if the sample is suitable. By suitable, I would mean more than 5 million moving spermatozoa. You can do even less than that, but recommendation would be 5 million in the prepared sample. If it's not suitable, proceed with ICSI and not IVF. If it's actinozoospermia, again, have a prepared sample. The prepared sample has got these 5 million or more motile spermatozoa. Think of IUI, a couple are young particularly, or proceed with ICSI. If it is azoospermia, confirm whether it's obstructive or non-obstructive. If it's obstructive, surgical correction is possible. A good urologist or an andrologist trained in surgical correction can do it. It's like tubal surgery for a tubal problem. It helps the couple achieve a normal conception. But if it's not possible, if it's not trained, or the couple are not willing, again, some couple don't want to wait, then you may have to consider doing sperm retrieval techniques. Sperm retrieval techniques are very effective. I would even say nearly 100%. You can recover sperm in almost all men. I would say 100%, but you never say 100% in medicine. So you say nearly 100%, spermatozoa can be retrieved in all men with obstructive azoospermia, either from the epididymis or from the testis. In non-obstructive azoospermia, if it's due to a hormone deficiency, the treatment of choice would be hormone therapy for restoring fertility. When some of these men report early in life, you may have to give androgens to restore their secondary sexual characteristics, but that will not help in fertility. When fertility is required, stop the testosterone and put the patient on gonadotropins. In borderline azoospermia, what we call maturation arrest and hypospermatogenesis, and patients with Sertoli cell-only syndrome, sperm retrieval technique is a treatment of choice. Again, it is not 100%. Our data indicates 40%. Some people claim 50%. This data goes up to even 80% if it's hypospermatogenesis. That's why histology is very crucial. Depending on the histology of non-obstructive azoospermia, the sperm recovery could be anything from 20 if it's maturation errors, 80 if it's hypospermatogenesis. Well, a word about prevention of male infertility. Body weight plays a crucial role, not only in women. Obesity impairs sperm parameters and also sexual function. Lifestyle factors affect, as I mentioned before, smoking, alcohol, they all matter. Erosion of the testis, if untreated, will lead to atrophy. If treated properly, you can restore fertility. Unidentified undescended testis, it happens even today. I have seen men even recently who have come with undescended testes unattended in their adult life. It's surprising, but it happens. Genital infections, again, should be adequately treated. If not treated, may lead to problems, lead to blockage. Comorbid conditions require adequate treatment. Medical drugs, this I want to re-emphasize because a lot of young men today are on drugs, particularly the PPIs and statins and antihypertensives. They all can impair sperm parameters and also sexual function. Surgeries can inadvertently ligate the vas, so please ask and tell your surgeon to be careful when he's doing a hernia surgery or hydrocele surgery. Environmental toxins, now the talk of the town. Well, they do affect fertility, but the effect is not going to produce azoospermia unless the patient is on testosterone. Fertility, a final word about fertility preservations. Today we are talking of curable cancers. Many young men with cancer are given a long life. So when most of the oncologists try to emphasize how to prolong the life, we need to talk to them about how we're giving life to those prolonged years. The fertility preservation is important. We need to sensitize the oncologist first and then the patient. And it is possible to, it's very simple to do as sperm cryopreservation in a man with fertility. And this should be started much before the chemotherapy starts. But equally important is young boys who come with cancers. So for these people, the only treatment available today is testicular tissue cryopreservation. This is still experimental. Whether it will be successful, we do not know. It has proven successful in animals. Maybe it will be useful in young men also. Well, at every consultation, when you find you reach the end of the road, nothing much could be done. You need to spend time counseling the couple. They have three choices: accept a child-free life, leave things alone, or adopting a baby, or offer them heterologous, it's their choice, heterologous insemination. Well, what will happen in future is very difficult to predict. ICSI came like a sudden blow from the blue. Before ICSI, people thought ICSI will not work and it was given up. Suddenly it came, same is true of in vitro spermatogenesis, in vivo spermatogenesis, and testis transplant. They're all in the pipeline. They'll become a reality. We need to wait and see. Let me conclude by summarizing again. ST and clinical examination are still very, very important. Semen analysis remains the single most important test despite all its limitations. Spermatozoa function tests have no clinical role. They are very useful research tool, nothing beyond that. Medical and surgical management have precise but limited role. Assisted reproduction, particularly ICSI, has revolutionized the management of male infertility. Remember, time is a crucial factor. I re-emphasize infertility is a race against time. There's no point in wasting time on unproven therapies. So in 2023, where are we with male infertility? We are at the crossroads. We're at the crossroads. One road leads to simplification. Other roads lead to a lot of complicated procedures. I would recommend go the simple way and plan to do what is essential for the patient rather than attempting unproven therapies. That's the team which helped in making the slides and any other data collection. Thank you very much.
Thank you so much, sir. Such a big topic. You made it so clear. I think it will be a ready reckoner for anybody who's the junior and who's joining into infertility practice. Thank you so much. Can I ask some questions from the chat box to you, sir?
Sure, please. I'm sorry if I had been again fast.
No, sir, no, sir. It's very clear. Very clear.
I learned from today to be slower than before. And please go ahead.
Dr. Sugant Kumar Enmoli has asked, can ROS analysis be considered as routine semen analysis for the future?
I would recommend not doing it at all. The problem is this, we went through it in the early part of our career. Those days when I started my career, people used to come with anti-sperm antibody reports. They may remember that. Anti-sperm antibody, the problem was they did it for both men and women. And the woman will be blamed. She's got antibodies against her husband's sperm. Leave alone, the poor woman is suffering with infertility. She's being blamed for producing antibodies against her husband's sperm. Reactive oxygen species is physiological. We made this mistake in menopause. We were over-treating menopause. And the nurses came and told us, look, all that you claim about menopause is your treatment is doing more harm than good. And this is true of reactive oxygen species. Reactive oxygen species is generated in all metabolically active tissues. Estimating ROS is not of any value at all. So don't do it. If you do it, you're stuck with it. Then you know how to interpret it. Don't do it at all. If somebody comes with it, you just explain to them, because the difficulty is only when they come with a report done elsewhere. It takes a lot of time to explain to them and say that this is normal, physiological. And that's the cue for apoptosis, and apoptosis is physiological. So I would not recommend doing ROS at all. A good semen, this is very important. Many general labs leave semen analysis to the junior most person because it's not very prestigious. You know, the younger, this has happened in many big hospitals also. The junior most person has to look at the semen sample and gives a report. That's not enough. You need to have a properly trained person. And if it does a proper collection, semen collection is crucial. You need to instruct the patient both orally and written instruction. Collect the sample, complete sample. See, they think like urine sample. They collect urine sample, you collect part of it and throw the rest. He must be asked to collect a complete semen sample. And then a good technician has a look at the sample. That's good enough. And beyond that, ROS, any of the spermatozoa function tests are not of clinical importance.
Thank you so much. So another question Dr. Sugant Kumar has asked, can the use of antioxidants in vitro produce better yield during semen processing?
Antioxidants in the in vitro sample?
In vitro, to produce a better yield during semen processing.
No, it doesn't help at all. Again, I'm sorry for being negative. It doesn't help. Using antioxidants or adding antioxidants to your semen sample in sperm processing now. That is not, people tried pentoxiflin before to improve the motility. Even to improve the motility, ultimately the bottom line is pregnancy rate. And there's no report. Now it's not very popular. At one time it was very popular. Pentoxiflin was used to improve the prepared sample for doing IUIs, and I don't know if anybody still continuing to use it at all. Don't make it more and more complicated. Make it as, in fact, this has been a problem. You see, let me give an analogy. 1980 is when IVF started. 1980 is when computer revolution started. I'm talking about all these changes. In 43 years, today you have a handheld computer which is more powerful than NASA's computer when they sent the man to the moon. I'm not exact. NASA's computer when they sent the man to the moon was less powerful than the iPhone or the smartphone you have in your hand. Today, what we have done is, IVF was very simple. The sperm and the egg are not able to meet. It's a tubal problem. That's what it started with. They are not able to meet, so they need to meet. That's what Robert Edwards and Steptoe did. And all you need is to bring the sperm and the egg together. If they're not able to fertilize, like very poor sample, you're doing ICSI. Beyond that, to improve things, doing all kind of things does not really help. Instead of making things simpler, we're making it more complicated. We're bringing in ERA, we're bringing in embryoscope, we're bringing in so many things which make it, we brought in IMSI. IMSI was really an IMSI for the sperm. It is all done more trouble than good for the patient because it makes it more expensive and you're also confused. An ERA report confuses you. That's why I'm saying make it simple. And what is important is a good experienced embryologist, a good experienced clinician. And these are the two elements. Of course, the patient's profile is important. A 42-year-old lady, no matter what you do, is not going to get pregnant. Do an ERA and doing an embryoscope is not going to make a difference because she has lost her fertile years. So age is a very critical element. Beyond that, adding in vitro antioxidants, I don't think help.
I think you disappointed so many people by saying
Absolutely.
antioxidants are not
I know
useful
people that-
orally or in semen processing.
doesn't
Many will
help
be
you
disappointed. Yes.
It's a waste of time.
Waste
As
of
I keep saying, time is a crucial element.
And he's asked, are there decline of semen quality post-COVID in America?
No, there is no evidence for that again. If a man is affected with COVID, and yes, or orchitis, yes, definitely it can be affected. And during the period of COVID, yes, any inflammatory process in the body is going to affect every system. Hepatitis is not going to leave hepatitis alone. Inflammatory process is systemic, it affects. But beyond that, both the vaccination and post-COVID recovery has been there. I'm not aware of any literature. We have not done data ourselves. I'm not aware of any literature which claimed that the fertility has declined post-COVID, neither for the man nor for the woman.
Dr. Jayam Kannan ma'am has complimented you saying cartoonistic great academics by Dr. Pandian. Cartoonistic academics. Cartoon and academics. Your pictures she's complimenting.
Thank you very much.
And she has asked a question. With present attention more on motility, is CASA coming back to light?
Yeah. CASA, I was fortunate to use the first person to use in Europe at that time. It is an American invention. It was, I'm talking 1985 to 87. It's an extremely useful tool for research. In practical use, you still need a good technician to focus the right area. The advantage would be in a large volume clinics. It takes time to do some analysis by a lab technician. In large volume clinics, you have a machine which is not going to give subjectivity. It's objective. It gives you output in no time at all. So that way it is useful. But whether it is useful in estimating motility, yes, it is useful if you're using a drug. For example, let's say you're using pentoxicillin to see if the motility is improved. Or let's say you're using an antibiotic. Pre-sample, post-sample, your evaluation is going to be subjective. You can't say, it can say rapid progressive. But the machine will tell you it ran at 50 microns per second, pre-sample. Post-drug, it is 60. So that kind of useful tool. But clinically, I don't know. I'm not convinced it's a useful clinical tool for small laboratories. Large volume laboratories, yes, it's useful because it's a rapid turnover. You see, you can see a sample, it takes only less than a minute for a sample. That is not possible for a technician.
Thank you so much, sir. Dr. Dakshinamurthy has complimented you on the presentation. Is asked DNA fragmentation, DFI. Please comment on DFI.
Yeah. How much time do you have? I think it is a really important topic, so let me take a little bit more time. Then, is it okay? Is it too late for all of you?
Yes, sir. Please, sir. Please, you can continue.
Yeah. DFI, DNA fragmentation is a normal physiological phenomenon. Again, we make many physiology into pathology, like we made with IMSI. Vacuole is a normal physiological phenomenon. We measured the vacuole and called it pathological beyond certain level. Let me take one more. When you do a DFI, you're not really looking at a fragmented sperm at all. What you do is you take a semen sample and subject it to stress, and then evaluate how many spermatozoa are DNA fragmented after the stress. Number one. Number two, strangely, you find in this situation alone, you're talking of percentages. If the people who claim it's useful, they say, if it's more than 30% or 15%, whatever percentage they give. Look at the anomalous situation. Let's say the volume is 1.5 ml. The concentration is 20 million. This man has got 30 million spermatozoa. Let's say 50% is DNA fragmented. Got 15 million non-fragmented spermatozoa. Is that not good enough for a conception? We don't know. Why did they arrive at this 15% and 30%? What is the logic in it? And after all, we all know that we need only one spermatozoa to achieve a conception. And with 15 million non-fragmented spermatozoa, the pregnancy not possible. And all the people who claim DNA fragmentation test also claim when you do ICSI, it is not relevant. It makes it even more awkward. When you're doing ICSI, you don't know which sperm you're injecting. This is a more serious situation. If somebody comes with a DFI report, let's say 30%, which means every third spermatozoa is a DNA fragment. And with that report, if I'm the embryologist, I'll be scared. If I'm injecting 10 oocytes, I'm injecting 3 of them with a DNA fragmented sperm. So why do it and add to your anxiety? And you do not, unless we have a test for identifying a single spermatozoa DNA fragmentation without harming the spermatozoa, these tests have no meaning at all. And ASRM is very clear about it. ASRM is very clear, and no professional body is recommending it as routine. You may consider it's again a research tool. It's a good research tool, but for practical users, it doesn't stand any scrutiny at all. It's a single fragment or double strand, we don't know. And again, oocyte has got a lot of corrective mechanisms. So with all these things, again, my recommendation would be don't do a DFI. If you do a DFI, you're in trouble because you do not know what to do with it. And how does it improve? And people claim, go to the testis. Why? If the DFI is there, it can happen at any site.
Any site.
In fact, if it happened at that site. That's where spermatogenesis happens. Beyond that, it's only transport. It's only a conduit. So with this background, I would say DFI is not a useful clinical tool. It may be a research tool, but not for clinical use.
Dr. Deepika has asked the same question, and Dr. Swaminathan has now asked, what is your takeaway message about ICSI for all?
ICSI.
ICSI for all.
Well, that's again, I moved over to ICSI for all after I burned my finger with my previous colleagues. This was in Brunei. When I went to Brunei in 2005, the previous batch had patient whose unexplained infertility with 12 oocytes. The embryologist in Brunei was a person, senior embryologist from Sydney IVF. Sydney IVF is one of the top centers in the world. And they came and did IVF. 12 oocytes, unexplained infertility, IVF. None of them got fertilized. So when I went and took over, this patient came and said, why was not ICSI done for me? Until then, I used to do IVF and ICSI based on the patient profile. She said, ICSI is there. Why was not ICSI done for me? I had no answer. So she was threatening to sue. So I had to offer her the cajole and convince her and say, look, we'll offer you a free treatment next cycle and do ICSI. Whether one case will make a difference? No, it doesn't make a difference. But when you are in the receiving end and you are the clinician sitting in front of the patient, and you have to tell the patient, and we know in unexplained infertility, 10% can have fertilization failure. Who's the 10% patient? You do not know. So I do today ICSI for all. It doesn't sound, that's, I think, the only non-evidence-based practice which I do. I think I may be doing other things, I don't know. All of the situation, yes, it's not indicated for everybody. But if you have the courage to do it, go ahead and try IVF in these patients. There are people working in the NHS who say, even when you have 3 oocytes, you do IVF. You can do it in NHS. The patient is not paying for it. And
Not
you
in
may not
India.
see the patient next time. They may go to some other doctor, or they may go to another clinician in the same clinic. But when you have to face the patient, and we all do it, now, private patients, private practice, you have to lend your shoulders to the patient. To do ICSI, you tell them, I did everything possible. So it's ICSI for all in my practice. I know it sounds a little harsh. There is not enough science to prove ICSI is superior. No, but ICSI is not inferior. So I'm happy ICSI is not inferior. So I do ICSI for all, though there are counterclaims that IVF is good at it.
So you're bold enough to accept that you're doing ICSI for all. I don't
Honestly,
think
this
many
is
will do
true.
that.
In fact, you look at data of people doing other PSs also. Is male infertility 70%? Those who are doing 30% IVF and 70%. Male infertility is not 70%. Why do they do 70% ICSI? No, 30% only IVF. They try to extend the indication. First, they start with IVF only for IV for tubal thing, ICSI only for male infertility. Then they go on extending, saying that less oocytes are obtained, or an older woman, the indication gets extended. So I think until there is evidence that ICSI is harmful, I feel it is safe to do ICSI for all patients because you have to face the patient and confront the situation.
Why not 50%, 50%, sir?
Yeah,
IVF
that's a
for
good
50
argument. This is like what we used to do before, when a long time back when I was doing gynecology, people used to remove one ovary and leave the other ovary. It's
Yes.
still being practiced, saying that one ovary for ovarian function and another ovary for removing malignancy risk. Does it work that way? Doesn't work that way. Which ovary will develop malignancy, we do not know. If you believe in ovarian function, leave the ovaries behind and count and follow her up. Same is true. Which oocyte will get fertilized, you do not know. 50-50 you can do. Problem is, which will you transfer? Why do you do 50-50? Do you do 50-50 because you think ICSI is harmful? And then do you separate them and do embryo culture only for patients with IVF and do the embryo transfer and keep the ICSI embryos? Now you're going to throw the embryo? Nobody has the answer. We all do group culture. All the embryos go into it. And which one you are transferring, you don't know. That satisfies your moral element. You think, no, I don't do all. But beyond that, practically, what is the advantage of doing it? We did it for a few patients because my embryo asked the same question, why not we do it? And when you do 50-50, you find the fertilization rate was better in the ICSI group. And I then asked him, you had 5 oocytes this side, only you got 2. You got 4 here. So would you still like to continue to do it? They said, no, we go back to ICSI. So you don't force it down. If you're a clinician, don't force it down the throat if you're embryologist. Reason with them and convince them that until ICSI is proven harmful, we're all safe. The argument is more expensive is meaningless. Expense is what you create. You don't have to charge the patient more. You offer the patient assisted reproduction and offer them a package rather than saying, if I do ICSI, I'll cost you more. And time-wise is again another ridiculous argument. You ask a good embryologist how long it takes. Less than a minute to do an ICSI. Less than a minute. If you're 10 oocytes, you've got 10 minutes more. Don't you think people have 10 minutes more to spend for a patient who's spending so much time? So it's time-consuming, more expensive, all fishless argument. It's not more expensive. It's not more time-consuming for a good setup. So I would recommend any day ICSI for all.
That will be the take-home message, I think. And the questions on CASA, sir has answered already that. Dr. Priya Kannappan is asking whether sperm preparation methods will improve the quality. Sir? I think this connection went on.
If you're talking of a motility pump initially with the MSC, I think in Katlaba. Okay. Am I seeing now? Okay.
Yes, sir. Yes,
got 30% motility to start with, a 7 neat sample. After preparation, you can get a 90-95% motile sample. For 2 reasons. One, sperm is viscous, 7 is viscous. The prepared media is not viscous. Second, you're getting only the motile sperm. So your final yield will definitely be sperm preparation methods definitely offer you a much better sample. What method you follow again is left to you. People again make all kind of claims like double centrifugation. I would say a simple swim up is good enough. A swim up does less damage. A centrifugation definitely harms the spermatozoa. You're spinning it. Remember, the smallest cell in the body is being centrifuged at 2000 revolutions per minute. That does damage itself. So I would recommend a simple and good sample, a good swim up is good enough, and that is enough for all IUIs, or for IVFs.
Thank you, sir. Dr. Kannagi from Coimbatore, she has said, thanks, Professor Pandian, sir. As usual, sticking to the guns of evidence and not recommending something because it is fanciful or we have nothing else to offer, she said. I'm intrigued by the statement that infertility is declining. Did I hear right? That's what ma'am is asking.
Yeah, well, I'm glad you raised this issue. If you go with WHO data, yes, it's declining. But if you go by worldwide data, there is no indication it's declining or increasing. And if you go and look at your patient population, when they come to you at 35 years, what do you expect? Your patient profile is changing. And look at the indigenous population. The incidence of infertility is 1%. Would you believe it if I say that? Do you think I must be crazy? You take people who are married in their teens. It's happening still. Less than 20. If anybody has got the time and the inclination, go and take people who are less than 20 and see what the incidence of infertility. It will be 1%. The incidence goes to 10% when they are married in 20s. It goes to 20% if they go in 30s. And it goes to 50% if they're married in 40s. And we put them all together and say incidence of infertility is 15%. 15% is a wheel of all age groups. And infertility is an age-dependent disease. Absolutely. So there is no, if it's declining, if you take the WHO standard, yes, infertility is declining. This is our own patient population. This is a tertiary referral center. We get only referred patients, and we saw your data. We saw the data that most men are not infertile, and the predominant reason for infertility is unexplained, which means there's no reason at all. Now, why are they infertile? They're infertile because they've lost their fertile years. They're simply coming at 35 and say, I'm infertile. They're not infertile. Maybe they have to try longer. But still it be there, it could be age-related decline. So if you take a 20-year-old now, a 20-year-old in the past, I don't think fertility is decline. That is the real measure. If you take 30s and 30s, it's not decline. Why would it decline? There are a lot of claims about environmental toxins. They all do harm, I don't deny at all. But if everything else is going up, your longevity is going up, your health lifespan is going up, why should this decline? And remember, this has got a barrier also. So I'm not convinced fertility is declining. I'm not saying fertility is improving. That would be a counterclaim. But our standards of fertility are wrong because we are basing it purely on the hospital population.
Thank you so much, sir. I think we'll close the session now. We are like so thankful to you that you took your precious time out to give us these inputs, all small points, but so precious. Thank you so much, sir.
Thank you very much. I enjoyed meeting all of you.
Thank you, sir.
Particularly Jayam, for a long time. At least you can see through the Zoom. So I'm so glad to get to know all of you. And great job, TTT, right? Trichy-Thanjavur-Tiruvarur, Thanjavur.
Thanjavur.
Great job that you're able to do it consistently. Online is the best thing. I think online is best rather than having insight, because insight is all right once in a while, but more to meet people. But this is great because all of us are comfortable sitting in our own home and enjoying a cup of coffee or breakfast or whatever. Thank you very much.
Thank you, sir. May I request Dr. Jayamkannan ma'am to say a few words before we give the vote of thanks with Dr. Nalina Devi.
Yes. Pandian, your talk has been so fantastic. I love the cartoons also because it's not that easy to have academics through cartoon. Because sometimes we get driven by the cartoons, but your cartoons were not eye-catching, but they were eye-promoting. And your ICSI for all is something fantastic. I think we are all into ICSI for the past 2.5 decades. I think from 1999, we have taken ICSI for all. As you said, why was I not done an ICSI when there is an IVF failure and she can take us to the court of law? That is a message that you have given to these people. And the second one about the varicocele, which you emphatically said no, is really eye-catching because varicocele refer to urogynecologists or urologist. All these refer, as Kamini Rao put it, RV reference departments, that is one thing we have to do by ourselves. And the simple semen analysis which you have explained is great. I would love Pandian to be back again, something for a little high-end topic, because we have started one and all the youngsters are going on happily from the remote rural areas to sub-metro areas. Okay, so probably when it comes to some tertiary care of infertility, I would like to love you to be back with all your tremendous knowledge on male factor infertility. Because many people may not know the volume of your research that you have done. Thank you.
Thank you so much.
Thank you for all this, Charmila, Shanti, Manjula, Nalina, and others who are the executives of these academics in assisted reproduction, which has been started for the benefit of these people. I'm just a backbone for them. They can fall on my shoulders at any time. With people like Pandian who are going to improve their capacity to really make infertility decline in the future. Thank you very much.
Thank you, ma'am. Thank you so much. Thank you, sir. May I request Nalina Devi to give the vote of thanks?
Am I audible, ma'am?
You're audible. Yes.
Respected seniors and colleagues, good evening to all. It is an immense pleasure to thank the legend speakers today, Dr. Kamini Rao Madam and Dr. Pandian sir, for the excellent speech they have given amidst their busy schedule to enlighten the junior colleagues like us in this AIRT webinar. And I also thank our team, respected Dr. Jayankana ma'am, Dr. Kamila ma'am, Dr. Shanti ma'am, for the arrangements of this webinar. I thank the Pharma Shield for the support and also the technical team, tech team for the technical help. Finally, the delegates also who have listened. Hoping to meet you all in the future such as ART webinar. Thank you.
Thank you, Nalina. Sir, she's from Perambalur. That's why the network is little poor, and
that's
she's
fine.
from a remote area, and she's one of our executives. Our president is Dr. Shanti Venkatakrishnan, and she's from Mayavaram. So we are
Okay.
from everywhere in Tamil Nadu, and we're
Yeah,
so
I am
happy
from-
to meet.
I was born close to Mayavaram in Peralam.
Okay, thank you,
It's a
thank
small
you.
bird.
Which village, Pandian?
Peralam. Peralam is
Peralam.
Peralam, okay.
Yeah, Peralam is such a big agricultural land.